So we are live in 3, 2, 1. Please start, sir. We are live.
Hello, good evening, everyone. It's a pleasure to welcome you all and everyone for this exciting webinar, Newer Treatment in the Management of Lung Cancer. It's a pleasure to welcome our convener, Dr. Abhishek Pathak, who is a senior consultant, head of the Department Medical Oncology at Command, Kolkata. We welcome you all for this exciting webinar on lung cancer. And without wasting any time, it's a pleasure to request Dr. Abhishek to set the ball rolling with his welcome and introduction. So, good evening, Dr. Abhishek. We request you to take the things forward, sir. Over to you, sir.
Thank you, Mr. Tarun. Thank you for this wonderful and good introduction. So, yeah, I think we have other doctors who have already joined.
Yes, Dr. Ashutosh Daga is already there. I think we can request him to start the presentation. You can introduce Dr. Daga, please.
Okay. Yeah, so before the introduction, there was a small comment which I already was thinking. Whenever we come up with these kind of CMEs and all, there's a lot of data which is thrown to us, and therein where I feel comes the role of subject matter experts, the oncologist and all, who could digest the entire data and give us in a manner which is much more easier and convenient for us to use it in our day-to-day life. So this is where I feel that there's an importance of all these CMEs to make our life much more comfortable. So starting with this session, I think we have Dr. Ashutosh Daga from NH Hospital. He is, I believe, if I'm not mistaken, an alumni of Adyar Institute, one of the most premier institutes in India, which deals with in oncology. So without wasting much time, I'd request him to please give his talk on chemotherapy in lung cancer. Dr. Ashutosh?
Yeah, hi, good evening. Am I audible?
Yeah, you are very much audible. In fact,
thanks. Thanks for the kind introduction, Dr. Abhishek. So I'll just share my slides. So are my slides visible?
No, sir.
Not yet.
Sure.
Is it now visible?
Yes, sir.
Yeah.
Okay.
Yeah, thank you. So good evening, everyone. Thanks, Dr. Abhishek, for such a kind introduction. And I'll like to thank all the sponsors, LCAM, and everyone here who is organizing this CME, which is very important part of our day-to-day learning and to update ourselves. So today my topic is regarding the role of chemotherapy and updates in the lung cancer. We all know that there's a huge paradigm shift in the management of lung cancer in probably in a half decade or so. A lot of precision molecules have come, a lot of immunotherapy data is coming across, not only in metastatic setting, in adjuvant setting, everywhere, and now in neoadjuvant setting also. So I'll try to wrap up the things quickly and see how the data is evolving in this particular segment. So we all know that lung cancer is one of the most common cancer. If we talk about the Globocon data 2020, it comes at the fourth number, and the lung cancer constitutes almost 6% of the new cases in both the sexes. And if we talk about the males, it is just comes after the head and neck cancers at the second number. Overall incidence rate falls at the fourth number. But if we talk about the mortality, if you see the figures, almost 72,000 new cases and almost 66,000 deaths. So the proportionate of conversion or the number of patients who are dying because of lung cancer is too much. There's a lot of unmet needs in this particular malignancy because of the bad behavior of the disease and the heterogeneity of the disease, not only the disease, but also the population. So this is just a snapshot of how the things have evolved in the last 6 or 7 decades, from where we have come across like best supportive care to single platinum chemotherapy to doublet, and how the things have now come across with the combination of chemotherapy and immunotherapy in the first line setting in NSCLC and SCLC lung cancer. So previously, we were only talking about the histology, SCLC and NSCLC. As the data emerged, we came to know that no, all the NSCLC is not similar. There is some portion of adenocarcinoma, there is some portion of small cell squamous cell carcinoma. So that has to be treated differently. In adenocarcinoma also, there is a lot of molecular pathology and molecular tests has come across now. We know that in metastatic setting and in adjuvant setting, there is a lot of role of EGFR mutational studies and metastatic setting like L-cross. And apart from that, there's a whole basket of mutations which we do in our NGS panel nowadays in clinics for the lung cancer. And also there's ISC for PD-L1, which we see what's the level of expression, how much they will benefit from the immunotherapy or the combination. So talking about all these data, what is the significance of chemotherapy in this precision medicine era? So almost, I'll say 1/3 of the NSCLC will have some kind of other driver mutation, either EGFR, L-cross, RET cross. And if we detect that, then the remaining 50% of them will have some kind of PDL expression, and 30% of the patients who are negative for driver mutations will have TPS score of more than 50%. So the patients who are not in this category will definitely benefit from the chemotherapy doublet regimen, which we use in NSCLC. Just a brief that how we treat NSCLC. For the stage 1A, we only give them option of surgery. Up till 3A, if they are resectable, we resect them. And in adjuvant setting, there is very good data based on the ADAURA for adjuvant osimertinib for EGFR mutation population. If not resectable, then we give them chemoradiation followed by durvalumab maintenance for a year. And in stage 4, it's a completely different scenario where we talk about driver mutations and we treat according to that. So almost 4 to 5 decades back, we were only talking about best supportive care. The median OS was somewhere around 3 months, 4 months. When we came to know, no, there's some role of chemotherapy, and the median OS has increased by almost 2 months based on the because of the platinum chemotherapy. There is definitely some added toxicity because of that. But the main paradigm shift in the chemotherapy came when we came to know that the chemotherapy doublets, especially the platinum doublets, have a lot of role in chemotherapy in metastatic setting, in adjuvant settings, especially if we combine the platinum with the third generation agents like vinorelbine, paclitaxel, gemcitabine, docetaxel. There was a landmark meta-analysis of NSCLC collaborative group, which came in 1995 in BMJ, and almost 10,000 patients were there in this. And they clearly told that the platinum-based chemotherapy significantly improved OS over the best supportive care in this particular subset. Talking about the metastatic setting, the ECOG 1594 study was a landmark study where they have seen 4 different regimens, all platinum-based, and they found out there was no difference between the different regimens, and all had a similar efficacy and the safety data. It depends on place to place. In US and as well as I think in Asia and India, we use more of carboplatin-based chemotherapy, whereas in Europe, they use more of a cisplatin-based chemotherapy. If you talk about some data, how it evolved, like the phase 3 GEM-DB trial, where we came to know the histology is very important, and pemetrexed has more clinical benefit in non-squamous than the squamous histology. Talking about the maintenance, the phase 3 JMEN trial told that the switch maintenance, if we use for pemetrexed, there might be some median numerous benefit in patients who are getting pemetrexed maintenance after the 4 cycles of platinum-based tablet chemotherapy. Talking about which platinum to use, there is meta-analysis that yes, CDDP have some benefit over carboplatin. It has more response rate, but OS benefit is very minimal. But if we talk about the combination of CDDP with the third generation chemotherapy, like as I told, like vinorelbine, paclitaxel, pemetrexed, gemcitabine. There is some OS benefit, almost of 10% over carbapetin, but it was again more frequently associated with more of a toxicity like nausea, vomiting. So we have to see what is our goal. If it is in a metastatic setting, I think carboplatin is a very reasonable option because the modest OS benefit of cisplatin is counteracted by the toxicities and the tolerance and the chemotherapy breaks which we get. And cisplatin will have some upper hand in settings of non-metastatic settings we are planning for a curative intent. Talking about the number of cycles, I think all of us practices almost 4 cycles. But as per the data, the 4 versus 6 cycles, there was modest PFS benefit of 6 cycles versus 4 cycles, but no OS benefit. We talk about the compliance for the 4 cycles is 80%, and for 6 cycles almost 50%. So if we increase the 2 cycles, the compliance drops by 30%. And the median OS was somewhat higher in the doublets for cisplatin-based chemotherapy as compared to the carboplatin. Again, a phase 3 study of the Paramount trial, which has seen the role of the maintenance of pemetrexed after the 4 cycles of PEMSIS, and this was the study which established that yes, pemetrexed maintenance after the pemetrexed platinum-based doublet chemotherapy will have both PFS and OS benefit, and from this trial only it becomes the standard of care. If we talk about the curative setting, like if the disease is not resectable, we give concurrent chemoradiation as a standard of care because the concurrent chemoradiation has shown superiority over the sequential. And what regimen to use? We have a very good data from phase 3 Proclaim trial, which has established that pemetrexed cisplatin is as equal and with less toxicity as compared to the etoposide cisplatin. So this is again the same thing which I already told you. This is from the ESMO guidelines, which recommend that the adjuvant chemotherapy in the curative setting, especially in the stage 1B, which is now a stage 2, as per the current AJCC 8th edition TNM, will have OS benefit from the adjuvant chemotherapy, especially if the primary tumor size is more than 4 centimeter. The other risk factor which we talk about in adjuvant chemotherapy is what is the grade of the tumor, whether there's LVSI, whether there's a visceral pleural involvement or not, and whether what was the type of resection, whether it's a wedge resection or a lobar resection. All these things can be considered if we are deciding for the adjuvant chemotherapy. And again, the landmark LACE meta-analysis has established that third generation platinum-based doublet will have will increase the overall survival, median overall survival of patients after the surgery in adjuvant settings. And the absolute benefit at 5 years was almost 5.4% between chemotherapy versus no chemotherapy arm. These are all the trials in the LACE meta-analysis, 5 trials they have included. And if we go across the stages, as the stage increases, the proportionate survival in the same stage increases with the chemotherapy. So with increasing stage, yes, the proportionate advantage with the patient gets increases. What about neoadjuvant versus adjuvant? So there's a landmark meta-analysis which was published in 2008, and that has shown that neoadjuvant is as good as adjuvant, not no much benefit, and some added advantage of resectability and arterial resections. If we talk about the newer advantages, we talk about ADC like trastuzumab deruxtecan. We talk about TDM1 now in HER2-positive breast cancer, HER2-positive lung cancer also. And these are novel molecules which have a antibody heavy chain with a linker and with a payload, which attaches specifically to a target. So not only it will have effect on the tumor, but also the chemotherapy will have some bystander effect also because of the diffusion or the penetration of the chemotherapy to the adjacent cells also. If we talk about the latest data in the HER2 positive mutated NSCLC, I think everybody is talking about the Destiny Lung 01 trial, trastuzumab deruxtecan. And if you see the overall response rate is somewhere around 60%, and the disease control rate will reach up to 90%. So this is a remarkable data which anybody, for any agent in metastatic setting, to have a disease control rate of almost 90%. These are all the things which chemotherapy which we use in NSCLC, in adjuvant or in metastatic settings. One particular thing which I want to point out is the recent CheckMate trial, which has established the role of nivolumab in neoadjuvant setting also. So now we have enough data for based on the PAT-CR rate, based on the PFS of the patients who have received nivolumab in combination with the platinum doublet chemotherapy in patients who are initially with a tumor size of more than 4 centimeter in the neoadjuvant setting. Again, if we talk about in the adjuvant setting, what has come up across recently is the osimertinib AURORA trial. I think everybody will discuss now here, and also the role of atezolizumab post surgery and post chemotherapy. The patients were put on 1 year of maintenance atezolizumab based on the IM Brave 01 study or IM Power 01 study, I don't remember correctly. But there was again PFS benefit of 1 year of atezolizumab. What happens to the patients who have received neoadjuvant immunotherapy with the platinum compound, whether they should receive in immunotherapy in the adjuvant setting? We don't have a data now. We don't have an answer to that now. Talk about the unresectable diseases based on the Pacific trial. We all know that the standard of care now after the definitive CTRT is 1 year of maintenance durvalumab for patients who have achieved at least stable disease or PR with the definitive CTRT. What other novel chemotherapy agents are used? I think there is mitaplatin, which is there, which have some activity in NSCLC in combination with doublet regimens. And if talk about the data in total, so the median OS is that it has reached up to 1 to 15 months from the platinum doublet agents in the third generation chemotherapy combinations. This is again something new which has come up in last 2 or 3 years, the combination of immunotherapy with the platinum doublet, both in squamous as well as adenocarcinoma. A lot of data, whether it depends upon the PDL1 less than 1 or 1 to 49 or more than 50%. If it's more than 50%, the disease burden is not that much. We are more inclined in giving patients who don't have driver mutations, giving pembrolizumab or immunotherapy combinations alone. But if it is less than 50%, the standard of care now is the combination of the IU and platinum doublet. So based on the Keynote 189, Keynote 407, which was in squamous setting, and IM Power 150, which has used bevacizumab also in the metastatic settings. One thing which I just wanted to add is the role of bevacizumab in metastatic setting is we can use bevacizumab in combination with the paclitaxel carboplatin, and it will have some PFS benefits based on the ECOG trial. Other particular group which we can use bevacizumab in combination with EGFR TKIs is exon 20 or exon 21 with erlotinib. There is a modest benefit of adding immunotherapy to bevacizumab in the IM Power Brave study. But if you're only using chemotherapy, especially the pacli-carbo, then there is some data that it has a good PFS benefit if we add to the platinum doublet. So this I'll end my talk and I'll be happy to have any questions.
Thank you, Dr. Ashutosh, for this a very lucid presentation. If there are any questions, I think, are there any questions? Okay, so just for my clarity, like what's your practice? Suppose a new patient with metastatic CA lung comes. So do you wait for the mutation studies, or do you start off the chemotherapy first? Like, what's the normal practice?
So if the patient is not that much symptomatic, so I like to wait because at least EGFR study will come around in next 7 to 10 days. But if the patient is having a lot of disease burden, is lot of symptomatic symptoms, then I'll start off with the either a paclitaxel or a pemetrexed carboplatin based chemotherapy and wait for the mutation studies to come. In my practice, because a lot of the patients cannot afford osimertinib, if it is a EGFR positive, then based on the Tata trial, we have enough data from the Asian population that combination of the platinum doublet with the EGFR TKI, you can achieve almost, I'll not tell the same, but almost same response rates, PFS with the platinum doublet and gefitinib versus osimertinib. So I prefer to give platinum doublet with the EGFR TKI in EGFR population.
Okay. So if the patient is symptomatic, you start off with paclitaxel and then probably wait. And
either based on the histology. If it's
okay.
Yeah.
Okay. No, very nice, very nice. And okay. So otherwise, you don't consider IO at this setting. You just wait for the reports and all.
Yeah, yeah, definitely. Because IO is one thing which I think in Indian context it is too costly to offer to each and every patient. So what will be the magnitude of benefit I want to see, and that I can only tell based on the IHC PDF.
So now, suppose if you give PEM carbo, probably you might be giving it 3 weekly. So like like in practice, just for my understanding, does giving one cycle actually make a lot of benefit, like or 7 days? Generally, probably we get it around 5 days EGFR mutation. So do you really feel that giving one cycle would make a lot of difference?
So my thought process is that if the disease burden is too much, anyways, I will add chemotherapy with either immunotherapy or with the EGFR TKI. So I'll start off with the chemotherapy, and based on the molecular studies, I will add either a EGFR or a immunotherapy based on the results.
Very good, very good. Yeah, very nice. So I just wanted to have some clarity that I hope I'm doing the right things, So wonderful, Dr. Ashutosh, and I think Dr. Charu is also there right now.
Yeah.
So very good evening. Dr. Charu has been a great help to us, and I think in my day-to-day practice, whenever I'm stuck, I give a call to her. So as we all know, she is a very senior person from MedGenome. So without wasting much time, I think we'd like to learn a lot from you because that's the aspect I think we're slightly weak in. So please go ahead and thanks.
Thank you so much, Dr. Abhishek. That's a great, I mean, it is a great introduction. So I hope I am able to give you a little interesting talk today. So, and definitely, I mean, at MedGenome, we would love to be associated with you as in a manner we have been. So my talk will be focused on genomic biomarkers in lung cancer. So it's a little broad topic, but I would have certain important points wherein I want to highlight a little about more some new updates that are coming up. So if we look at non-small cell lung cancer, we all know it's a high load cancer, and almost I mean it's kind of in India, if you look at the data, 70 to 510 cases of lung cancer were reported in India, which constitutes almost 5.5% of all cancers. And non-small cell lung cancer is particularly making 85% of all the lung cancer cases. So it includes subtypes as adenocarcinoma, squamous cell carcinoma, large cell, and certain non-differentiated carcinomas as well. And over the last 20 years, we have seen a great shift from cytotoxic therapies to personalized therapies. And I think non-small cell lung cancer is kind of a model disease wherein the relevance of using targeted therapies has just changed the scenarios for even other cancer types, and has given opportunity to the molecular and the molecular oncology field per se to work on different molecules. So if you look at the frequency of oncogenic drivers in non-small cell lung cancer, we all know there are certain markers which are very well established, like EGFR, ALK, ROS1 fusion, RET fusion, MET amplification, HER2 amplification, or FGFR, HRAS. So all are these all are your cell signaling pathways, and certain molecules that you will find very commonly mutated, like EGFR is almost 30%, KRAS is 29%, and out of that 39% alone is KRAS G12C, and certain other mutations which are found at a little lower percentages. So if you look at the molecular testing for non-small lung cancer, this is the latest version of NCCN guidelines released on September 26th. And if you look at the modifications, there are little modifications that have been added, which is about the broad molecular testing. So they have defined the broad molecular testing as an important advising. That means the panel strongly advises broader molecular profiling with the goal of identifying rare driver mutations for which effective drugs may already be available, or to appropriately counsel patients regarding the availability of clinical trials. So this is a major, I think, improvement in terms of NCCN, where they are actually focusing on using broader molecular profiling rather than doing a single gene or one gene at a time, or doing two genes and then waiting for the other genes to, one gene to come negative and then go to the other one. So this kind of approach, I think, can really increase in terms of getting improvement of care for patients with non-small cell lung cancer. Also, another thing which is highlighted here is that if there is insufficient tissue to allow for all EGFR, KRAS, ALK, ROS1, BRAF, NTRK, RET, MET, HER2, repeat biopsy or plasma testing should be done. So if these are not feasible, treatment is guided by available results, and if unknown, these patients should be treated as though they do not have driver oncogenes. So herein I will just like to make a point. If there is an insufficient tissue and you know that the tissue itself, the pathologist can let you know that you have a little tissue only, and then there are very less chances in terms of looking at fusions per se, because fusions require the tissue more importantly, and plasma testing can be done for point mutations. So EGFR pickup rate in plasma testing is quite good, and so I would suggest that rather than going ahead directly for EGFR only, and not going for a panel based approach, definitely it depends on what amount of tissue is there. You can go for a liquid biopsy panel, and if you do not find anything there, then you go on switching on to the tissue if the case is critical, or you are doing a repeat biopsy there. So those kind of modulations can be done after talking with the molecular a person in molecular medicine, or your molecular pathologist. They can guide you on basis of the tissue availability and the marker that could be tested with certain approaches. Now coming to the testing methodologies for non-small cell lung cancer. Obviously, NGS is most preferred in terms of doing the testing, because you can do different number of genes with a single test, and NCCN also mentions that most typically broad panel based approach should be done for patients who in broad testing do not have identifiable driver markers, especially in never smokers. RNA based NGS, if not already performed, should be done to maximize the detection of fusion events. So these things makes it very clear that RNA-based NGS is required to detect the fusion events. So that's why I was saying that if you have a less of tissue, you can still detect the DNA-based mutations of EGFR and KRAS and your HER2 by liquid biopsy, but the RNA-based NGS requires the tissue, and then only the fusions can be picked up. So you can devise your molecular testing in the similar fashion and create an algorithm accordingly at your center. Other thing which I want to highlight here is that we have to be careful about if we are getting a variant of unknown significance. Any classified variant which is a VUS, even if in a gene which is in which other variants are clinically actionable, should not be considered as a basis of target therapy selection. So just the presence of gene mutation is not the answer. What that mutation is actually doing, whether it has a good clinical evidence, or or it could be correlated with any clinical trial or something, then only you should go ahead by using that particular report. So it is important that the report has clear identification that whether this mutation is actually creating is involved in the disease progression or not. So then coming to the biomarkers, which we all know. So in EGFR, we have now 3 different categories. First are the common mutations, that is exon 19 deletion, L858R, and exon 19 insertion. So they are responsive to your TKIs like osimertinib, erlotinib, and gefitinib. However, certain uncommon mutations like L865Q or G79X, these are responsive to afatinib and osimertinib. Patients having T790M, they show resistance to first and second generation TKI, only osimertinib shows response. And patients with exon 20 insertions, they either have to go for a systemic therapy, that is your chemotherapy, and in the subsequent therapy line, that is second line, you can use amivantamab. I think amivantamab will soon be available. I just heard that there are certain trials also going on, I think at RGCI in Delhi. So definitely you can get your patient enrolled there if there is an exon 20 insertion. So ALK-KML4 fusion, the gold standard is definitely FISH, but as mentioned in NCCN, RNA-based fusion has to be done. And similarly, you have KRAS, ROS1 rearrangements, BRAF, and NTRK123, MET exon 14 skipping mutations, amplifications, and other mutations, RET rearrangements, PDL1 expression, HER2 mutations, and TMB. So all these have to be part of the broad panel which you are using, because there is great importance of doing all these genes and getting the update. So if you look at classification of EGFR mutations, as we just discussed, there are few mutations which are related to osimertinib resistance, also T790M, C797S, and there are some second site mutations and exon 20 insertions, which are also primary resistance mutations. So targeted PCR based approach can lead to under detection of exon 20 insertion, and NGS is preferred. So if you, you cannot anticipate a exon 20 insertion. So definitely I think PCR can miss it, because PCR will not have all the region covered for exon 20. So I think NGS is a better choice. And if you look at the T790M, if it is detected in the absence of EGFR TKI therapy, then genetic counseling and possible germline testing are warranted in case of these patients who present with T790M before even getting treated with the EGFR TKI inhibitor. Then you have FGFR fusions. So now I will be discussing a little on EGFR TKI resistance. So FGFR fusions have been very infrequently reported in non-small cell adenocarcinoma. including these are like rare or acquired resistance mechanism following the treatment with EGFR TKIs. So after the EGFR TKIs are being given to the patient might develop a FGFR 1, 2, 3 fusion. And there has been a study which was just recently published, which shows that patients with EGFR mutant patients progressing on EGFR TKIs, they developed the FGFR1 fusion and they were selected. And 23.8% of cases had FGFR2-3 mutations along with EGFR sensitizing mutations like exon 19 deletions. So they actually found that combination of EGFR TKIs and FGFR TKIs can represent a promising therapy of in case of such patients where you find out FGFR 1, 2, 3 fusions after treatment with TKIs after a point when they start showing resistance. So I would suggest that in case of EGFR TKI resistant patients, I think in the coming time, we will have to broaden up the testing, not just stipulating it to T790M or C797S. There are other pathways that could be involved in acquired resistance. So one of them is FGFR. Next is ALK resistance mutation. So similarly, in case of ALK, we see that patient who is in crizotinib after some time stops responding. So the molecular mechanism involved ALK mutations, other bypass tracks, and some unknown regions also, or an ALK amplification. So ALK mutations we can definitely detect with the help of NGS, both in FFPE and cfDNA samples, that your cell-free DNA samples. And lorlatinib, I think, is now become has the strongest activity for most common ALK resistance mutation. And then we have different drugs like seribatinib, alectinib, and brigatinib, where you can find different possibilities as per your mutation which you find. You can look at the IC50 and choose the drug. Then you have RET alteration. I think selvatinib has now become an FDA-approved drug for all kind of tumors across the pan-tumor marker. So we find the most common rearrangement is intron 11 RET and intron 15 of KIF-PV gene, which is most commonly found in terms of patients with younger patients who are non-smokers. Then MET gene alterations. So this is also a very interesting gene alteration in terms of MET has altered activity in numerous ways. It can be a MET overexpression. It can be a MET amplification. It can be a MET mutation. So including the key exons 14 skipping mutation and MET fusion. So there are several ways by which MET gene can actually get involved in terms of carcinogenesis. Among patients who are non-small cell lung cancer, exon 14 skipping mutations occur in 3 to 4%, and exon and MET amplification occur in 1 to 6% patients. And if you look at MET fusions in lung adenocarcinoma, in those negative for any common driver mutation, they are only 0.5% patients who will have a MET fusion. So the unique MET 14 skipping mutation can be detected by NGS or a hotspot, which is testing which leads to decreased ubiquitinization and increased proliferation. So basically what happens is the exon 14 is completely missed out, and the mRNA which is formed is exon 13 and exon 15. So whole of your because of the mutation at the splice site, the exon 14 is deleted, and your protein becomes having one exon less. So it completely changes its function, and it leads to increased proliferation. That's how exon 14 skipping mutation occurs. It is found both in smokers and non-smokers, and slightly better slightly more detected in more elderly patients, women, and non-smokers. So now MET amplifications. So we have also seen that MET amplifications are related to EGFR TKI resistance. If you look at the EGFR TKI resistant mechanism, MET amplification has been reported in 5 to 20% of patients with first generation EGFR TKIs. So it might be as high as 25% in those who progress on third generation EGFR TKI. So when you are doing a EGFR TKI resistance workup, I think MET amplification also has a major role to play, because the percentage is very high. Like, it is almost 1 in 4 patients. So MET amplification can be evaluated through FISH, or next generation sequencing can also pick this up. So a broad panel will help you. And if for the confirmation, you can do a FISH also, which is, I think, very routinely available. Then you have ROS1. ROS1 is found in 1 to 2% patients. These are majorly rearrangements, and patients are often light smokers or non-smokers, and they are young. Crizotinib is the treatment, and patients of ROS1 who have CNS metastasis, their enterictinib works better because it can cross the blood-brain barrier. So I think that is more important in CNS metastasis patient. Coming to the KRAS mutations, so KRAS, as we all know, is now becoming it's a very commonly found mutations. So alongside it works for you in terms of EGFR TKI it can give you responsiveness towards EGFR TKI therapy if a patient is EGFR positive and also KRAS positive, and it is also associated with your expression towards immunotherapies. So if a KRAS mutation is present, it can give you a better indication that the patient will respond better to immunotherapy. That is one another insight which I had just read a few days ago. So that's an important thing to add here. And targeting KRAS, we definitely have a new drug which we talk about, but I think still has to be available for the patients to be used, and it is still not given as a first line. It is still in the subsequent treatment lines. So next, coming to PD-L1 testing. So we know that there are several clones which we can use, and tumor proportion score is given in case of non-small cell lung cancer. So here we have 22C3, we have for pembrolizumab, and for SP263, where we can, if come positive, we can give the therapy in first line, but you have to be sure about the percentages. More than 50% only you can give the immunotherapy as an individual first line, and in 1 to 49% patients, you can give it in first line in combination with chemotherapy. Tumor mutation burden is also very important marker being done in non-small cell lung cancer because of the high smoking index generally the patients have. This leads to mutations in the whole genome, in the coding regions of the genome, and these mutations can be correlated to high neoantigen level, and the patient will have a anti-tumor immune response. Now coming to liquid biopsy. I think liquid biopsy has a major role to play in case of lung cancer patient because of the very major issue of the lung being a very typical site for a biopsy, and doing a repeat biopsy is an issue which becomes difficult in terms of when you have to monitor the patient and when you have to find out whether the patient has the mutation or has developed resistance, or even sometimes at the start of the diagnosis you are not able to biopsy the site because of the location of the tumor. So in all those situations, liquid biopsy can come to rescue, and now it is becoming a standard of care per se. So it is recommended by all the international guidelines, and they have recommended the use of ctDNA as first method to discover molecular resistance mechanism, because if you are doing only for molecular resistance, then you are majorly looking at point mutations only and amplifications which can be picked up with NGS. Nowadays such a technology is available, and so due to simplicity and high patient advocacy, this is more preferred for molecular resistance mechanisms. So this is just a flow chart where I have tried to put down what is the algorithm of using liquid biopsy. So targetable resistant mutations, if it is absent, then you go for a tissue rebiopsy, and feasible, then you perform a molecular analysis using NGS and you find out a driver mutation and do a PDL1 alongside. So once targetable resistant mutation is detected, then you treat with the therapy based on the oncogenic driver. So this is definitely the pathway in patients who are progressing or recurrent disease during the treatment with TKIs. Another important thing which I would just like to put forward while closing my talk is parallel versus sequential testing. So you can go for a parallel approach or a sequential approach where you are doing DNA and RNA NGS together, or you are doing it sequentially. So sequential approach, I think, should only be preferred if you have less amount of tissue. Because even if you have good amount of tissue, then wasting it on IHC, I don't think makes sense, because then for NGS it becomes an issue to to actually report all the genes, so a very judicial use of the tissue is required. I think we have to be very upfront with the molecular pathologist or the oncopathologist at your centers, that when they are preparing the FFP block, doing the histopathology, they should be giving an indication to you that this tissue whether has the enough amount or not. If doesn't have, follow the approach. If the patient, and also in all this scenario, I think we have to consider how much the patient can pay and how much, what are the financial constraint we have as particular to the case. So I think a very important aspect is to look at sequentially using DNA RNA. It is the most efficient strategy for mutation and fusion detection in smoking associated non-small cell. So if you look at this is just a data which might help you when you are deciding for certain patients. And if you look at the parallel approach, it is more feasible to use on small tissue samples, including cytology tests, because it will reduce the complexity and cost for molecular workup, and also provide flexibility while you are evolving as the molecular landscape of non-small cell lung cancer is evolving. So I think those are the points from my side, and if there are any questions, I would be happy to answer. Yeah, thank you so much.
Wonderful talk, Dr. Charu. Really, you have covered almost everything in a brief span of time. So if there are any questions?
Charu, this is Ashutosh.
Yeah, hi, sir.
Hi. I just wanted to ask, in your clinical practice, how much concomitant mutations you see? I mean, dual mutations, dual driver mutations in samples. And second, can you please elaborate that where to ask for a RNA-based NGS? I know you have covered in your topic.
At MedGenome, sir, you can get an RNA-based NGS.
No, in which scenarios? Means
I think in all the scenarios you should do it. Our lung cancer panel has the we detect the mutations using RNA based NGS only.
Okay. And the first question, how many patients in your setting you have seen dual driver mutations in a single patient?
So dual driver mutations we do get, I think, in somewhere around not more than 5% patients right now, but I will just have to look into the data better and then get back to you. I will not just give you a number. But very recently I saw a patient with 2 EGFR mutations, one in exon, and they both of them were in exon 21 only. So those kind of cases we keep getting. And we also find patients who have an EGFR along with a ROS1 or an EGFR with a RET mutation. So these kind of cases we have reported, and I can just look into it better and get back to you on the correct numbers. Yeah.
Okay.
And if you want my help on, I can definitely assist you in terms of if you want me to dig down studies on terms of where there are more than 2 mutations, how those patients, how are these to be treated. So I can look into clinical trials, and if you are associated with us, we can work in that way. Yeah.
Yeah, thank you so much. Thank you.
Thank you, sir.
Dr. Charu, what is your a question which comes to mind? Why has there been so less work done in small cell lung cancer? So
Yeah, I think I also wondered it a lot of times because I also worked in when I in my PhD, I also worked majorly. We also wanted to get non-small cell only, but we used to get small cell lung cancer patient also. Primarily, I think one thing is that the disease is so aggressive. What I feel that there has not been much work done because the disease is so aggressive. By the time we detect it, I mean, there is not much to be done. And also, if you look at the data, they have done there is extensive work going on, but they have not been able to find out certain modifiers which could work for small cell lung cancer patients. However, I think with the upcoming immunotherapies and certain AI based approaches, there might come a time where we'll have certain insights about the small cell lung cancer biology also. I have just worked on irinotecan toxicity in case of small cell lung cancer patients, and only certain other markers, but other than that, there hasn't been much of insight of how to go about those patients other than the systemic therapies that are available.
thank you, Dr. Charu, for this wonderful talk.
Thank you, sir. I also liked it, and thank you so much. I think it's very important for us to interact because then we also understand what has to be done at our end. Thank you so much.
Thank you. So moving forward, I think now there has been a slight change, and Dr. Chandrakant would be speaking now on early breast cancer. I think Dr. M.V. Chandrakant needs no introduction to any one of us. He is a very prominent medical oncologist of, I think, India, and he is presently in the NH hospital. So without wasting much time, we will be very eager to listen to the talk of Dr. Chandrakant. So
thanks, Dr. Abhishek, for that very kind introduction. Okay, so it's a very nice meet, very targeted topics and targeted discussion. So let me share my slides. Okay. So this is okay. So I will be in coming 15 minutes. I will be discussing on ADAURA trial, that is adjuvant osimertinib in a resected non-small cell lung cancer. So if you look into lung cancer, 1 in 3 patients with non-small cell lung cancer present with resectable disease. This number is little less in our scenario, but looks like good number of patients have a resectable disease. What you can note is the recurrence rate, So 30% of patients will have resectable disease, and you can see the stages, stage 1B is tumor size more than 3 centimeters but less than 4 centimeters. This is stage 1B. And then stage 2 and stage 3A, these are the subset of patients which qualify for resection followed by adjuvant therapy. So if you look into lung is a more systemic disease than a local disease. In contrast to other malignancies where it is more local and less systemic, lung is more systemic and less local. So therefore, even if you resect these tumors, mediastinal lymph node involvement actually dictates recurrence rates. So therefore, if you look into even a stage 1B tumor, which is node negative, the recurrence rate is 45%. That's the number. And stage 2 and stage 3 invariably have 60 and 75% recurrence. Therefore, lung cancer needs adequate systemic therapy even if you resect it. The recurrences are usually local and also systemic. And very importantly, the hazard ratio of benefit with platinum-based chemotherapy is marginal, somewhere around 0.89, 0.84 for disease-free survival. That means what? This means that lung cancer has a lot of recurrence. Nearly 50 to 75% patients with resected lung cancer have systemic recurrence, more systemic recurrence. But we are not able to prevent that recurrence even with the available platinum-based therapies because the hazard ratio is 0.84, 0.89, sort of modest benefit only. Therefore, there is an unmet need to have a good systemic therapy. There is an unmet need where you would have a hazard ratio which is more impressive, which will cure more number of patients. So it's more systemic disease and this needs good systemic therapy, but unfortunately, what we have is only chemotherapy with chemotherapy. The hazard ratio is not impressive. Then coming on to the EGFR mutation prevalence, irrespective of stage, whether it is an early stage or an advanced stage. In our scenario, it's somewhere around 20-25%, in Indian scenario. This is how common we see EGFR mutations, and this EGFR mutations are independent of the stage of the disease. That means it's there from the beginning itself. It is not acquired in the later part. So it's a driver mutation and it starts early part of the disease. Therefore, the incidence of EGFR mutation is uniform irrespective of the stage of the disease. So this is the trial which we will discuss, the ADAURA trial, that is adjuvant osimertinib versus placebo in stage 1B 3A EGFR mutant non-small cell lung cancer after complete tumor resection. 1B means tumor size more than 3 centimeters. So this is the ADAURA phase 3 double-blind study design. You can see the inclusion criteria 1B, 2, 3A. This is what is the resectable subgroup of lung cancer means. Age more than 18 or 20, performance status, and then it included exon 19 and exon 21, L858R. Brain imaging was required if not done in the baseline. And very important is the maximum time between surgery and randomization is 10 weeks without adjuvant chemotherapy. Somewhere around 10 weeks, it's a 2.5 months, or 26 weeks with adjuvant chemotherapy, somewhere around 6.5 months. So this is the time interval that we need to remember, and it was randomized in 1:1 fashion. And you can see the number of patients, 682, big trial. So it was randomization was 1:1, osimertinib 80 milligram once daily versus placebo once daily. So remember the primary endpoints was disease-free survival by investigator assessment in 2-3A, and then designed for superiority under the assumed disease-free survival of 0.7 hazard ratio. Then secondary endpoints are DFS in overall population, overall survival, safety, and quality of life. And so treatment continues until disease recurrence, treatment completed, discontinuation criteria met. So these are the reasons for discontinuation. Either treatment is completed for 3 years, or disease recurrence, or there is some unexpected toxicity. on these situations, the drug is discontinued. And very importantly, following the IMDC recommendation, the study was unblinded early due to the promising efficacy. Here they report an unplanned interim analysis. At the time of unblinding study, the study had completed enrollment and all patients were followed for at least 1 year. So this was a unplanned unblinding or an unplanned interim analysis looking into the efficacy of this drug. So this is the inclusion and exclusion criteria. I think similar what I said. Very important exclusion criteria are who had segmentectomy or wedge dissection, or who did not meet the time duration from surgery to randomization, or those patients who required neoadjuvant chemotherapy or who required some radiation at any point of time. So these were actually excluded from the trial. So you can see the baseline characteristics. What is important is the staging, 1B, 2, 3A, almost in among all the stages, there has been a equitable distribution in both the arms, and 55-45, like this is like any other ratio. Even in a metastatic setting, we see a similar ratio. And very important is the last row, where you can see that 60% patients required adjuvant chemotherapy and 40% patients did not need adjuvant chemotherapy. And this is the result, how osimertinib improved disease-free survival versus placebo. You can see in stage 2 and 3A, the hazard ratio is 0.17 for disease-free survival in 2 and 3A. Whereas if you include the overall population, that includes 1B also, the hazard ratio is 0.2, which is statistically significant. You can see an early separation of curves. So 83 and 80% reduction in recurrence. And you can see the hazard ratio for DFS is consistent. It is best with 2 and 3A. With the stage 1B, the hazard ratio is 0.39. Is the 2-year DFS percentage. And you can see the subgroup analysis, irrespective of the type of mutation, whether the patient received adjuvant chemotherapy, whether it was 1B, 2 or 3A, or Asian, non-Asian, all of the subsets had favorable benefit with osimertinib, and you can see the hazard ratios are all impressive. And this is the overall survival. It was not reached in both the arms. The hazard ratio is 0.4. What you have to look is in this curve. So at 3 years, once the osimertinib was stopped, there was a larger recurrence, which I will show in the further slides. But overall survival data is still immature. So these are the data for other TKIs, and you can see the benefit is not that promising like osimertinib. They do show some benefit, but the hazard ratio is not that impressive like osimertinib. So this is the type of recurrence that we see with osimertinib versus chemotherapy. What you need to remember is, if you give osimertinib versus observation in the versus placebo patients had more recurrence when compared to osimertinib arm, and placebo arm had more distant recurrence. So you can see the last bar, where you can see the placebo arm has more distant recurrence. It has more recurrence and it has more of distant recurrence. Whereas osimertinib takes care of distant recurrence. The systemic therapy component is really good. Therefore, it shows more of local recurrences. And this is important, where CNS as a site of recurrence is taken care of by osimertinib because it has excellent blood-brain barrier penetration. So these are the sites of recurrence, and very impressive is the CNS recurrence. Only one CNS recurrence versus 10 CNS recurrences in the placebo arm. Very impressive. So osimertinib as an adjuvant therapy has an excellent systemic effect. It has far less recurrences. It has far less systemic recurrences than the placebo arm. So this is the difference in CNS recurrence, 10 times less recurrence with osimertinib. And this is the CNS disease-free survival. You can see that after 3 years, the moment you stop the drug, you can see the CNS recurrence just happens soon. So probably we have to continue the drug beyond 3 years is what we, indirectly understand. But this is the data right now we have. And then looking into the adverse events, osimertinib is a fairly well-tolerated TKI among all the 3 generations. Rash, diarrhea are a little bit concerning. Otherwise, it's quite manageable. Then coming on to, there was a criticism that 40% patients did not receive chemotherapy. So was the benefit because the comparator arm did not receive chemotherapy? So to answer that, there has been a good subgroup analysis. You can see the number of patients receiving adjuvant chemotherapy in stage 1B, 2, 3A, for like in LACE meta-analysis, we give adjuvant chemotherapy who have a T size more than 4 centimeters. So therefore, stage 2 and 3A actually qualify for chemotherapy, cis-Vino or PEM-CIS as per the institutional practice. And stage 1B with some high-risk features, they also qualify. Therefore, stage 1B, around only quarter of them received systemic therapy as adjuvant. And then, so this disease-free survival difference persisted whether they were given adjuvant chemotherapy or they were not given adjuvant chemotherapy. And the hazard ratio is 0.16 with adjuvant chemotherapy. This is because adjuvant chemotherapy was mainly given for stage 2 and 3A. So that subset received adjuvant chemotherapy. That is a subset that benefited most with adjuvant osimertinib for 3 years, versus the stage 1B group, which did not receive adjuvant chemotherapy, had a much lesser benefit. Therefore, there is nothing to do with chemotherapy and osimertinib's efficacy. Again, this is the DFS stage by stage, with or without adjuvant chemotherapy. All of them benefited with osimertinib. And this is again the DFS in patients with or without adjuvant chemotherapy. So these are the multiple in different stages, in all the stages, there has been a benefit with the adjuvant osimertinib. Whether you gave chemotherapy, you did not give, all the 3 stages benefited. Then coming on to patient reported outcomes. So you can see the patient reported outcomes, the compliance was good. The patient reported outcomes were impressive. This was sort of a safe drug. The physical and mental component summary were comparable. So to summarize, adjuvant osimertinib is the first targeted agent in a global trial to show a statistically significant and clinically meaningful improvement in disease-free survival in patients with 1B, 2, and 3A EGFR mutant non-small cell lung cancer. 80% reduction in the disease recurrence at death was seen with a hazard ratio of 0.2. Osimertinib versus placebo, DFS rates at 2 years was 89 versus 52% respectively. Adjuvant osimertinib demonstrated a clinically meaningful improvement in CNS DFS compared with placebo. the safety profile was consistent with the established safety profile of osimertinib with mild EGFR TKI class effects reported, and median duration of exposure to osimertinib was 22 months. So, a clinically meaningful DFS was seen regardless of the adjuvant therapy, and it had a better systemic control than local recurrence. That's what we understand. The health-related quality of life was well maintained. So adjuvant osimertinib will provide a highly effective, practice-changing treatment for patients with 1B, 2, 3A EGFR mutant non-small cell lung cancer after complete tumor resection. So this is one of the practice-changing trials where this made us to do EGFR testing in all resected non-small cell lung cancer more than 3 centimeters. And the recent data is that the moment you stop the drug at 3 years, the recurrences are happening. So we don't know, whether to stop at 3 years or we need to continue more. This is one of the thoughts that we must have. But this is efficacious. Hazard ratio is excellent. And you could see the hazard ratio with chemotherapy is 0.8, and here it's around 0.2. So in EGFR mutant resected non-small cell lung cancer, ADAURA should be practice changing. So thanks all of you, for patient listening. And back to you, sir.
Thank you, Dr. Chandrakant. As usual, a very lucid talk, which we could understand, for all of us. And definitely, ADAURA does show that adjuvant osimertinib is practice changing. However, there's some slight doubts which I want to clarify. Like even in FLORA trial, what we did see was the initial outcomes were amazing. There's no doubt in that. But when the OS was seen, then in particularly it was quite surprising that in Asian subgroup and also in L858R population, the outcomes were not very, very promising. In fact, it was quite surprising that the hazard ratio was 1, which means means it didn't work. So like in a stage 3A patient with L858R mutation, would you be very comfortable in giving maybe 3 years of osimertinib / maybe PEM-CABO or Paclitaxel, whichever adjuvant that you want to give for 4 to 6 cycle? So just your comments.
So yeah, so very valid comments, sir. So coming to standard of care, if a patient qualifies for adjuvant chemotherapy, the patient will receive adjuvant chemotherapy followed by osimertinib maintenance. So we don't want to take a chance, even though the evidence is there that even you can give osimertinib without chemotherapy. But I would prefer, even there are some comments to the main paper where they also prefer giving adjuvant chemotherapy followed by osimertinib if a patient qualifies for adjuvant chemotherapy. And secondly, coming on to the differential efficacy of exon 19 versus exon 21, yes, I agree. Exon 21 is a different, biologically different subgroup which has more concomitant mutations, which needs more than a TKI monotherapy. I would agree, but in the adjuvant setting, we don't have such subgroup separation as of now. Probably later on they will have the subgroup analysis. But if you look into the forest plot, as far as the disease-free survival is concerned, it is benefited. And the overall survival results are awaited, and we have to see and wait for the events to happen in either of the arms and look for the OS benefit. But this trial looks interesting. A lot of recurrences happened at the end of 3 years once you stop the drug. So the question was, are you really delaying the meds or are you really curing? The tail of the curve was not that well seen because there were a lot of recurrences once you stopped osimertinib. So the duration of osimertinib is sort of, should it be going on and on and on for more longer time, or we stop at 3 years? This is the question that everybody has in mind right now. As far as Asian versus, the study was not powered, even the aura, it was not powered to find out the survival difference in the ethnic subgroups. It was a subgroup analysis. Therefore, the study is not powered for OS differences among the subgroups. It is difficult to comment that Asians will not benefit. So, and if you look into us, we are either Asians or Caucasians, somewhere we are in between. So, this is the data we have. ADAURA, I think, is practice changing, and all the guidelines have recommended this. So, in the present day, with you could see that nearly 50 to 75% patients have relapse even if you resect, and the hazard ratio with chemo is 0.8, and majority will recur in spite of adjuvant chemo. So, having the unmet need in front of us, if a patient qualifies for ADAURA, I think we should offer the patient, knowing that stopping it 3 years, he may recur and maybe we have to continue longer.
Yeah, very nice. I think you clarified almost everything. And thanks a lot, Dr. Chandrakant, for this wonderful
Thank you, sir.
talk.
Thank you, sir.
And, next, I will request Dr. Pradeep Mandal, sir, to please take it over from here for the role of bevacizumab in lung cancer. I think Dr. Pradeep Mandal, sir, requires no, he's a very well-known, very famous medical oncologist, and presently he is associated with Medica Super Specialty Hospital. So without wasting much time, I'll request you, sir, to please give your talk.
Pradeep sir, your screen is not visible.
Yeah, I was sharing.
Sir, can you go to page 1?
Yeah, now it's visible.
Yes, sir. Yes, sir. Very much. Sir, can you go to page 1?
Yeah, it's visible, no?
Yes,
Hello?
sir. Yes, sir. Yes, sir. Very much visible, sir.
Okay. Thank you, Dr. Abhishek Pathak, for giving me this opportunity to talk in this forum. It's a nice talk by Dr. Chandrakant. So good evening, all respected colleagues and dear friends. So today I will talk about bevacizumab from principle to practice, its role in lung cancer. So first of all, before starting the talk, we have to understand that how angiogenesis develops and its role in tumor development, and how it's basically helps in tumor progression and disease progression, the role of angiogenesis. So basically, angiogenesis is one of the hallmark of cancer that leads to malignant growth. So this picture is depicting that most important mechanism of developing cancer, that is the hallmarks of cancer. So these are the different mechanism. One of them is that inducing angiogenesis. That is one of the most important for the survival and progression of the cancer. So this is the angiogenesis that's it's the essential for tumor development and progression. So this if you see that whenever tumors are more than 2 millimeters, that requires basically independent blood supply for their growth and survival. So basically that in blood vessels there is continued VEGF expression. So there are that in along with VEGF, there are lots of other angiogenesis inducing factors like beta FGF, TGF beta 1, TLGF. Now, all these things usually recruits along with that VEGF that usually give rise to that persistent persistent stimuli for the development of new vessels in the tumor. So that ultimately gives rise to the vascular and large tumor with metastatic potential, and tumor vasculature that is usually abnormal, and it's inherently unfavorable to the effective anti-tumor therapy. So basically, that is that angiogenic switch that leads to the overexpression of different pro-angiogenic signals and activation of different secondary pathways already discussed. So basically, critical role of VEGF that has been shown and throughout the angiogenesis. So it usually causes activation through that various stages that usually that may occur through the various stages of the tumor development, and it's mediated primarily by interaction of the VEGF-A and with the VEGF receptor 2. VEGF usually binds to the capillary endothelial cell receptors that generates a downstream signal cascade, and that promotes the angiogenesis. Basically, angiogenesis correlates with the disease progression in many tumors. It facilitates the survival of the existing endothelial cells, and it contributes to the vascular abnormalities. It stimulates new vessel growth, and it increases the vessel permeability. So bevacizumab precisely targets this VEGF to inhibit the angiogenesis, and thereby it causes the continuous tumor control. So basically, bevacizumab prevents the binding of the VEGF to its receptors, and bevacizumab basically had a long elimination half-life, around 20 days, which may contribute to the continuous tumor control. So precise VEGF inhibition may facilitate combinability and avoids the off-target toxicity. So basically, it's by bevacizumab there is precise VEGF inhibition that may contribute to the ability to combine bevacizumab with chemotherapy, and it avoids the occurrence of the off-target toxicities that usually with strategies that inhibits the multiple pathways. So the discovery and mechanism action. So basically in very early in 1970s, that Boltzmann proposed that tumor angiogenesis concept, and isolated that tumor angiogenesis factor. Later on, that in 1989, that VEGF was isolated by the Ferreira, and in 1993, that murine anti-VEGF monoclonal antibodies shown to inhibit the tumor growth in vivo in 1993. In 1997, that humanization of that murine anti-VEGF monoclonal antibody, that is bevacizumab, was done. And in 2004, bevacizumab demonstrated a major overall survival benefit in a phase 3 trial in metastatic colorectal cancer. In 2011, that bevacizumab was approved in the 5 different indications, and that almost a significant number of patients was treated with this beautiful targeted therapy. So bevacizumab can be effectively combined with the conventional treatment. So it is approved in different first-line options like first-line metastatic colorectal cancer, and it's proven effective with different kind of regimen like Folfox, Zelox, Folfiri, even with capecitabine, 5-FU-leucovorin. And in also approved in first-line non-small cell lung cancer. It has proven efficacy along with platinum-based chemotherapy. It's also approved in first-line metastatic metastatic breast cancer. It has proven efficacy with taxane and capecitabine. It is also approved in metastatic RCC along with interferon. Though nowadays we rarely use this drug. And in recurrent GBM, it is also approved as a single agent or with a chemotherapy like irinotecan. And in ovarian, even in neoadjuvant and recurrent setting, that in ovarian carcinoma, it is approved. So bevacizumab is basically a recombinant humanized anti-VEGF monoclonal antibody. It is 93% human and 7% murine, and it recognizes all the major isoform of the human VEGF. Its terminal half-life already discussed, is around 20 days, is a range of 17 to 21 days. So the mechanism of action, it causes regression of the existing tumor vasculature. It causes inhibition of the new vessel growth, and it is an anti-permeability of the agent of the surviving vasculature. So these are the three different mechanisms of action. It also causes regression, inhibition of new vessel formation, and also prevents the permeability of the vessels. So that causes early and continued effects in maintaining that normal vasculature, potentially improved drug delivery and inhibition of the tumor growth and metastasis. So first is the regression of the tumor vasculature. So bevacizumab causes the regression of the existing tumor vasculature. And regression of the tumor vasculature, there is a reduced tumor blood flow and weight and volume of the tumor. So there is always reduced tumor size, and there is microvascular density also decrease, and that also give rise to the reduced tumor size. Next is the inhibition of the new vessel growth. Inhibition of the new vessel growth, there is suppressed angiogenic activity, and there will be slow tumor growth when bevacizumab acts on the tumor cell, and it acts as an anti-permeability of the surviving vasculature. So without bevacizumab, you see that the vessel is quite leaky, and bevacizumab through inhibition of the VEGF induced VEGF pathway, it's reduce the permeability of the existent vasculature. So with reduction in the vessel permeability, there is always reduction of the vessel diameter, decrease interstitial fluid pressure, and then this all give rise to the reduced chances of developing metastasis in tumor. And there is continued bevacizumab to prolong angiogenesis inhibition, and it's maintain the tumor control. So this slide I've already seen that there is always continued effect of bevacizumab in tumor. So phase 3 trials have showed that continuing bevacizumab to disease progression delivers and proven clinical benefit. And so due to continuous VEGF expression and the potential for the vessel regrowth, so it is a different clinical trials have been designed with bevacizumab to continue until the disease progression or unacceptable toxicity, and it is recommended that bevacizumab be continued until the progression of the underlying disease. So angiogenesis is a key driver of the tumor development across different tumor types, and VEGF is an early and persistent promoter of the tumor angiogenesis, and bevacizumab precisely target this VEGF to inhibit the angiogenesis for the continuous tumor control through different mechanism like that regression of the existing tumor vasculature, inhibition of the new vessel growth, and anti-permeability of the surviving vasculature. And it's precisely inhibits and allows the allows to combine with different conventional chemotherapy. And bevacizumab first line maximizes the clinical benefit through proven control of the tumor growth, and continue bevacizumab to prolong angiogenesis inhibition and maintain tumor control. So beyond when you continue bevacizumab, even there is continuous growth retardation through this continuous angiogenesis inhibition. So bevacizumab in non-small cell lung cancer. So there are so I'll skip this slide. The burden, the therapeutic plateau, chemotherapy, all these things will skip. So overview of the bevacizumab, so there are two positive phase 3 trials in the first line setting. That E4599, this is a significant overall response rate, PFS, and the OS benefit when bevacizumab was combined with paclitaxel carboplatin versus chemotherapy alone. Another trial is the AVAL trial, which has shown significant overall response rate and PFS benefit when bevacizumab was combined with cisplatin plus gemcitabine versus chemotherapy alone. And efficacy findings was substantiated in cell. It is a large non-randomized observational study, and ARIES is a registry study. Here also its efficacy has been seen. So this is the first line bevacizumab, that is the E4599. Previously untreated stage 3B or 4 non-squamous non-small cell lung cancer was randomized. Two arm was there. One arm was the bevacizumab 15 mg per kg plus paclitaxel carboplatin was compared with the paclitaxel carboplatin. So randomization was 1:1 person, and in bevacizumab arm, bevacizumab was continued until disease progression. There is a maintenance therapy. Primary endpoint of the study was overall survival. Secondary endpoint was the overall response rate, progression-free survival, and it was stratification factor was measurable disease, prior radiation therapy, prior weight loss less than 5%, and according to the disease stage. So if you see that primary endpoint, that is the overall survival. So bevacizumab plus paclicarbo, there was 12.3 months of overall survival, and compared to 10.3 months with an hazard ratio of 0.79. So 21% improvement in the events in the bevacizumab plus chemotherapy compared to the chemotherapy alone. And if you see that that in planned subgroup analysis, that OS benefit was significant in patients with adenocarcinoma. That when bevacizumab was compared with chemotherapy, there was almost 4 months difference in the median overall survival. If you see the progression-free survival in this study, there was 6.2 versus 4.5 months of median overall survival with an hazard ratio of 0.66. And if you see the overall response rate, that was almost 35% in bevacizumab plus chemotherapy arm versus that chemotherapy alone, where it was 15%. Next is the cell. It is an bevacizumab in non-small cell in routine oncology practice. There are 6 cycles of bevacizumab along with standard chemotherapy, followed by bevacizumab maintenance until disease progression. Primary endpoint of this study was safety, and secondary endpoint was time to tumor progression, overall survival, safety. So ways in routine oncology practice in this cell, that it was consistent with that other phase 3 data. And basically there was 18.8 months of median OS was achieved in responding patients when treated till progression when compared to that chemotherapy. And a consistent median overall survival in the first line bevacizumab in this different study, it was seen when compared to the chemotherapy. So E4599, ARIES, AVAL, in all group that there was median overall survival benefit was there with bevacizumab. So next is the AVAPAL study that around 400 patients was screened. So first line induction chemotherapy is BEV plus PEMCIS. When there is a complete response or partial response, when there is a response according to the RECIST, patient was randomized to arm A, that is bevacizumab maintenance, and arm B was bevacizumab plus pemetrexed maintenance. 123. So median follow-up time for this analysis was 11 months, and in BEV plus PEM, when compared to the BEV, that's 10.2 versus 6.6 months of PFS from induction, and with an hazard ratio of 0.50. And that PFS from randomization, that BABE plus PEM, it was 7.4 versus 3.7 in the BABE alone arm with an hazard ratio of 0.48. So PFS in subgroup analysis, that that combination of BABE plus chemotherapy is favoring in most of the subgroup when compared to that bevacizumab alone. If you see that overall survival when BABE was combined with PEM, it was not reached versus BABE alone, it was 15.7 months with an hazard ratio of 0.75. So first line therapy with cisplatin plus PEM and bevacizumab was well tolerated with no new or unexpected toxicities were observed. And so the AVAPAL trial meets the primary endpoint, that first line PMC is BABE followed by continuation of the maintenance with bevacizumab plus pemetrexed achieved a PFS benefit of 10.2 months in an unselected non-small cell lung cancer patients population across all the different subgroups, and both the regimens were well tolerated. And OS data favors the continuation of maintenance bevacizumab plus pemetrexed, that is still immature. And overall, the AVAPAL result strongly favors the use of bevacizumab plus pemetrexed as continuous and maintenance therapy in patients with non-small cell lung cancer. Next is the Point Break study. It is the phase 3 study in previously untreated stage 3B or 4 squamous non-small cell lung cancer patients. Here 4 cycles of BABE plus PEM carbo was compared and followed by the bevacizumab plus pemetrexed maintenance until disease progression, and another group where bevacizumab plus pacli carbo and then bevacizumab maintenance until disease progression. Primary endpoint was the overall survival. Secondary endpoint was the overall response rate and disease control rate, PFS, and time to tumor progression, safety and quality of life. Point Break study, basically between the two groups, there was no difference in the overall survival. So hazard ratio was same, hazard ratio was 1. So there is no difference between these two regimen. And if you see that PFS in intent to treat population, and PEM carbo BABE was slightly better PFS when compared to the pacli carbo BABE with an hazard ratio of 0.83, not much of different. But more patient needed supportive care on the pemetrexed arm when compared to that pacli carbo BABE arm. So basically it has that bevacizumab has category 1A recommendation from the ESMO guidelines in this when bevacizumab combined with a pacli carbo regimen may be offered to patients with non-squamous non-small cell lung cancer without any indications, and combination of the bevacizumab and other platinum based chemotherapy may be considered in eligible patients of non-squamous non-small cell lung cancer. It is recommended. So proposed treatment algorithm for advanced stage non-small cell lung cancer when patient in non-squamous EGFR wild type, and if patient is bevacizumab eligible, then platinum doublet along with bevacizumab followed by BABE maintenance. If patient is bevacizumab ineligible, then platinum doublet. And in so two randomized phase 3 trials have demonstrated significantly improved PFS and overall response rate when bevacizumab was combined to the standard first line therapy. And overall survival benefit in bevacizumab was particularly seen in the subgroups of patients with adenocarcinoma, and different observational studies like SAIL study and ARIES registry study in routine oncology practice are consistent with the efficacy data from different randomized trials. So this is the cell that is consistent efficacy benefit in ASEAN patients and in overall population, that overall survival benefit is there. So I will stop here. That bevacizumab had in different clinical trial has shown that even in first line, when compared to chemotherapy alone, when we add bevacizumab in non-small cell advanced non-small cell lung cancer, there is overall survival and progression free survival benefit, and with an mostly well tolerated and that toxicity profile is not much of difference with when we add bevacizumab. So bevacizumab can be added in advanced non-small cell lung cancer along with chemotherapy. Thank you.
Thank you, Dr. Mandal. It was indeed a very good talk. And I think your last statement was what summarizes everything. Bevacizumab can be added. I think the way you ended it up was the crux of the whole story. You know, with so many things happening in this non-small cell lung cancer, I think bevacizumab was slightly left behind. You know, and there have been multiple trials which is trying to bring it back, but I think it all ends up with what you ended it up, that there is an option that we can add it up and it can be used. I think that is perhaps the take-home message. Are there any questions related to this? I think there are none. So maybe we can shift to the next case-based study. Are all the panelists there? Dr. Ashutosh, Dr. Chandrakant, Dr. Pradeep, you're already there?
Yes, sir. Yes, almost.
Oh, everybody is there. Okay.
Yes, sir.
Dr. Charu is also there. Huh? Okay. Very good. Very good. So yeah, I'll just share my slides. So I think most of it has already been covered, but nevertheless, we'll go with this small case summary. Just give me a moment. Okay. So I hope my slides are visible.
Yes, sir. Very much.
Okay. So we would be discussing a case of management of metastatic EGFR mutated non-small cell lung cancer. So before starting, Dr. Pradeep, I would just like to know that in a month, how many new cases would you be actually seeing? New cases of metastatic lung cancer in totality, you know, whether EGFR mutated or not mutated, irrespective of that.
So you're asking about the new or
new cases? Yeah, new cases.
New cases. Huh? New cases maybe around in a month. New cases probably I see around five new cases I see in my center. 5 to 10 maybe probably in
5 to 10. Okay. So we'll keep a figure of around 8 maybe on an average. Okay. And Dr. Chandrakant, how many new cases would you be seeing?
Same number, sir, same number.
So on an average, I think we can keep that every week we are seeing at least 2 new cases of metastatic lung cancer. And if we can take an average, maybe all of us, let's keep it a 50%. One of them is an EGFR positive. So this is a big chunk that we all see it quite often. So just let's go on with the case. So he is a 54-year-old male, a former smoker. He is diabetic. ECOG is PS0. So he was suffering from pleuritic chest pain and had some shortness of breath. And as luck would have it, he had got a lung mass, which is 42 into 37 millimeter. And he has got a right adrenal mets. And histology wise, he's adenocarcinoma. Okay. So it's a stage 4 NSCLC. Okay. Dr. Ashutosh, are you there? I think is not there. Okay.
Yes.
So,
So Ashutosh sir is here.
okay. Maybe, okay. Okay, anyways, so the patient was diagnosed as a case of metastatic CLC adenocarcinoma, and the molecular panel was EGFR mutated L858R. So I think the first, I would like to get the opinion of Dr. Charu. I know because she is somebody who who would give us an insight. So what would be your take? Like we all have got, EGFR, ALCross, PDL1, some kind of coupons and all. So do you suggest that we should go all out with the complete lung panel, or what is your take on it? Dr. Charu is there, but I think. Okay, so Dr. Pradeep, you could just tell us what do you normally do? Do you like, it does appear very impressive when Dr. Charu gave that talk that we should do, the complete profile. There could be chances of co-mutations. So there are endless possibilities that can happen. But what do we do in practically? What are the first tests that we actually ask for?
So in my clinical practice, that most of the time we do that specific EGFR, ALCross, the common mutations in most of the time. But actually in because tissue is a problem, so you may not get that much of tissue. So it's better to do that comprehensive genomic panel. That NGS will be the best thing, so that in one shot you can see that what are the targets. So that will be better. But in most of the times, because of that affordability and all this thing availability, we are not able to do that comprehensive genomic that NGS in most of our clinical practice. So we do the specific EGFR, ALCross, the common mutation testing in most of the time.
Okay, so very nice, very nice. I think that's all what we do normally. So just to give a slight twist to the case, Dr. Chandrakant, suppose instead of the adrenal met, it was an oligo-mets which could have been, tackled very well, skeletal mets maybe, and that too a single skeletal mets, which could have been tackled by maybe an SBRT or any radiation form. So will that management change, like whether we have a oligometastatic disease where we can give a local therapy and probably give a local therapy to the lung also, but we have an EGFR mutation also. So would you in practice change, or would you take it as a metastatic disease and go ahead with that?
I think lung is somewhere the oligomets thing is not that. It's more systemic, You could see a resected tumor recurs, and to have a long-term control with a definitive therapy to all the sites is quite heroic. So I would always start him on systemic therapy, and in later part, if that is the only site which is left, maybe I would consider, but not at least in the initial part. So this patient needs systemic therapy. So that's how I look into.
So one of those EGFR TKIs have to be in place, whichever that we decide upon. No, very true, very true. So Dr. Charu, are you there?
Yes, so Charu ma'am is here.
But I think. Okay, so maybe we'll go ahead. Okay. So I think the next question would be the commonest one. What would be the choice of treatment? So I think this is no brainer. Dr. Chandrakant, what would be your approach?
So it's L858R,
Yeah.
So and this is an Astra sponsored one. So I mean, osimertinib, if there is brain mets, it's osimertinib, but if no, then there are multiple options. Second generation TKI is quite impressive for exon 21. Erlo Ram or Erlo Bav have done really well, and PEM Carbo Jeff also has done well. So if you look specifically at exon 21, monotherapy with osimertinib has not that shown well, even though We are not supposed to do subgroup analysis. If there is brain mets, osimertinib. If not, still osimertinib. But if a patient is not affording, that's fine. Second generation TK also works well.
Okay. So the options are second generation versus Dr. Mandal. What would be your choice?
Yeah, yes, sir.
So,
So-
do you also agree with, yeah.
So if patient is affordable, then my first choice with that osimertinib will be the first choice.
Okay. And if, okay, so basically here we are not keeping the cost constraints. We are just having an academic discussion. So you feel osimertinib is the first choice. Okay.
Hello.
Yeah.
Hello.
So even, you can see it, it has been given as recommendation first line. So I think there are a lot of things which require a lot of time for discussion into this, but we'll keep it very safe and simple as of now. So what are your consideration while choosing the treatment options in EGFR mutated lung cancer patients? Dr. Mandal, please.
Hello.
Yeah, Dr. Mandal, yeah, please.
Okay. So overall survival is that, of course, that is in first line option. Overall survival is the best consideration, is the primary consideration, followed by, of course, that safety, quality of life. It comes next. The overall survival is that primary consideration.
Okay. Dr. Ashutosh, are you there? Dr. Ashutosh?
Am I audible?
Yeah, you're just audible. Yeah,
I'm
please,
sorry,
please go.
I don't know what happened in between. So
Oh.
just one thing I wanted to ask all the seniors here.
Yeah.
We always talk about the cross-trial comparison between the Archer and the Flora study. But one thing we tell that in Exon 21, the dacomitinib is doing a little bit better than osimertinib. But if we talk about the inclusion criteria, the Archer study has never included the brain met patients. I think that is one of the most significant point in EGFR positive patients with the brain metastasis not there in the trial, and then also we are comparing with them. I think it's a little bit unfair for the osimertinib part.
Yeah, I think Dr. Chandrakant was referring to the same aspect when he said that, if there is a brain mets, probably he had no, he was very much convinced that osimertinib is the drug of choice. But in absence of brain mets, probably he had, the equal efficacy of all those different medicines. So what, according to you, is the most important thing? Are you looking straight away at OS or quality of life, safety, or efficacy? Dr.
I think for any EGFR positive patients, first line OS. For me, it's OS.
Yeah, I think all of us would agree that all these drugs are relatively well tolerated. So it is OS which we are really worried about. And then as we see that, most of these trials, whether you have erlotinib versus geftinib or afatinib versus gestanib, it was just the Flora trial which actually brought in a remarkable, advantage of using an osimertinib. So I think this is where we all agree that I do agree with Dr. Chandrakant that in case of absence of brain mets, we can discuss that later on. But as of now, we can keep osimertinib to be a relatively one of the best options that we have. So, yeah, please.
Can I tell you? Yeah. So the Archer study, the primary endpoint was, I think, response rates.
Yes.
And they have never gone and seen the OS data because the expected response rate has not met the significant criteria. I think that is one also point for which I'll be more comfortable in using osimertinib rather than the dacomitinib.
Yes, I think you're very true. Archer trial was, if you see, even statistically, it was not supposed to comment on the OS because its initial parameters were not fulfilled. So that's very true. I think Dr. Charu is here, so we
Yeah.
should have some question for her.
So sorry. Yeah.
So we'll come back to you the basic question. Like all of us here feel that we should get the basic things like EGFR, Alcross, PDL1. That's the basic that we are getting it done. So the costs are definitely a constraint. So how can you convince us that we should get an NGS done straight away and not get this, the initial test and so what's your
Yeah, so I think during my talk also my whole point was around the same thing only. See, I will not put it like you should do it for every patient, because every patient will have different other factors playing a role, like financial factors, or even if they can afford a drug after they do a test. So irrespective of that said, I think that I think what you should start considering is the tissue. So the major problem which we face with lung cancer majorly is about the tissue insufficiency and the tissue not being available, or the tissue, even if available, not being the fixation is not done properly, so we cannot process the complete test or something like that. And in when you are doing these IHCs or fish testings, and if you get a EGFR Alcross1 negative patient, so it's particularly, I think it's nowadays it shouldn't be a call of just leaving it there, because we know that there are other options now coming up, and the drugs are also getting more and more available. There are compassionate programs, there are clinical trials that are going on. So all these things have to be considered, and keeping all those things in mind, if we use the tissue in doing a single IHC one by one, and that wastes a lot of tissue and creates then you are left with nothing. So I think the cost of IHCs, and if you look at the cost and benefit analysis, doing an NGS will always have more cost to benefit ratio. So that's what I think I have seen in all these years, and that's what I actually believe in also, that there has to be an algorithm at every center which has to be put in place, looking at the internal facility of pathology they have, and the molecular lab which they are working with. So they have to be closely associated. And in the past times, I have done such kind of modifications at my own personal levels, where I have worked with the pathologist of a certain center, and given them help in and aid in terms of whether when they are doing a rebiopsy, or whether it can help them in terms of deciding whether to go for IHC directly, or go for NGS directly, or go for a more broader panel. So I think clinical conditions, and also the the demographics of a patient also have to be evaluated, and then you can keeping all those things in mind, I think with more and more experience we will get to a place where we can give the best possible solution to every patient. Yeah.
So very good, Dr. Charu. I think you made a very comprehensive statement that it depends on a lot of factors. We cannot have a very compartmentalized approach to each and every patient.
Yeah, I mean,
So-
obviously, as a genesis or as a clinical genomics expert being in this field, I will definitely, I know the benefits of NGS, and I think molecular, even the clinical oncology, if you look at per se, they are also very well aware of that these days, because of the increased awareness and increased benefits it has. But looking at the different setups, which I mean, I get a chance to go to extreme kind of extreme northeastern states, and some districts also. So when I look at those areas and look at those facilities, I think that we are still not there, and we still have to work a lot on getting it available for everybody, and making it not even available. It is available, but being available and getting used is a different thing. So there is a gap which needs to be bridged up, and we can make it better by having a multidisciplinary approach, where your pathologist and your clinical oncologist and your molecular oncologist, or a molecular person, molecular biologist or a geneticist, can come together and find the best possible solution for that patient. So,
Right. So, Dr. Pradeep, what about this? Will type of mutation change your choice of EGFR TKI? Something we have been discussing. But
Yeah,
does
of
it
course.
practically change? Yeah.
Yeah, of course. That if you see that if patient had that uncommon mutations where that this first line EGFR TKI even don't work. So in that case, that probably osimertinib will be your only choice. Osimertinib or afatinib, afatinib or osimertinib will be choice. And probably in that in resistant kind of mutation, like if there is upfront T790M mutations is there, then of course that you have to choose your EGFR TKI accordingly. So the type of mutation of course that to change that our choice of EGFR TKI.
Okay. So, Dr. Chandrakant, Dr. Pradeep mentioned about upfront T790 mutation. So, are we looking into it?
So it depends on which platform I do. If
Sorry.
I do a proper CGP, I will get it. But if I'm doing a hotspot for these sensitive mutations, I don't. So even if you look into the exon 19, exon 21, again, in that also we are doing hotspot. We are not looking into the whole genome, So many a times, if you do a hotspot or a targeted PCR, you may miss it. When you do a CGP, you will get it. So something like cryptic EGFR mutations, which are not usually picked up on routine. So ideally, we must do T790M because 5% of EGFR mutations have T790M, and these patients, need osimertinib in the frontline setting. So ideally, we must do, but we are not doing. At least in 90% patients, we are doing targeted 1921 only, and rarely some exon 20 insertions, and so rarely we do. So exon 1921 is what we are actually focusing on.
And suppose I think what you were highlighting, Dr. Charu also highlighted in her talk that targeted PCR would miss on a lot of things. But suppose we cost being no constraint, and we all have osimertinib with us, and we have EGFR mutation coming up, and we know that we can give osimertinib. So is there a point doing a T790 at this point of time?
So it is prognostic, like T790M baseline versus exon 19. The progression-free interval will be shorter for a T790M. And T790M may have concomitant mutations also. So this is something like a bad subgroup where I will be looking for a shorter progression-free interval than exon 19.
Fair enough. So
also, I would like to add a point. If it is a frontline T790M without any EGFR therapy, it also had certain germline thing to it, but we have to look at the VAF, the variant allele frequency, definitely.
So germline, in the sense, family history of lung cancer, is it?
Yeah. NCCN says it.
So
it's only T790M, not any other.
Yeah, that's the only mutation they mention.
So this is what we see, that more or less this chart shows that it works equally good on both of them. Definitely, it's better for DEL19. So this we all agree. And definitely, this is the point which Dr. Ashutosh was trying to make, that Archer trial actually removed all those patients with CNS mets. So we cannot actually compare this. So this is how, the whole, main trials, Lux Lung 7, Archer 1050, and Flora, they all have been combined together. And there they showed that what is the advantage of actually using osimertinib, which was very convincingly proven in the Flora trial. So it has shown the highest median overall response rate. So how important is overall survival for picking EGFR TKI for our stage 4? So we have already discussed this. Since we are thinking about TKI, so OS is a very, very important thing for us at this point of time. So there was improvement in OS when we had this the survival analysis, which was the secondary endpoint. And it did show that we have an advantage of giving an osimertinib. So these trials could also be, further we can discuss over it. But for the paucity of time, we'll keep it, simple. And this is what the Archer trial, and this is what Dr. Ashutosh was trying to highlight, that we cannot take up the outcomes of Archer trial in OS because the ORR was not statistically significant, and hence the OS could not be concluded from the trial outcomes. So similarly, this says that no statistically significant improvement in the OS was demonstrated in Archer 1050. So we come to the next question. While choosing EGFR TKI, can you ignore the risk of developing CNS mets in your advanced EGFR non-small cell lung cancer? I believe Dr. Chandrakant made the opening statement that CNS mets is one of the most important things that we need to consider. And so definitely this goes more in favor of osimertinib. So do you routinely do brain MRI for all stages of all stage 4 patients, Dr. Ashutosh? Even if they have no CNS complaints?
If you talk ideally, yes, but in clinical practice, no.
Okay, not even a contrast CT of brain?
Clinical practice, no, because most of us are getting PET scans. Ideally, we should do, but I am not doing for everyone in clinical practice.
Okay. So Dr. Chandrakant, if you have a whole body PET done, which also gives you some clue of the brain thing, would you like to get an MRI done of brain of not or not?
I and Ashutosh, practice together, we are always patient-centered, patient-centered. Patient dictates what they want,
Okay.
So we don't do it, as a routine. But yes, in a patient who can afford and who is willing for investigations, definitely, because brain mets is one of the criteria to choose a TKI.
Yeah. And as for small cell?
Small cell, limited stage, yes, not for extensive stage. If asymptomatic, we don't do.
Yeah, so maybe I'm slightly better off with these things, so we get an MRI done. So it's a free thing. So yeah, okay. So yeah, the same thing, whether we'll be missing out on asymptomatic CNS mets or not. So yeah, this will be discussed. So as per the data, this day, for the guidelines, we are supposed to do it, but as you said, it depends on a lot of other aspects. Okay. So what we could make out was that in Archer, brain mets were included. Flora, they did include stable brain mets, and also in LuxLung 7, they had used it. So coming to the same point, finally, significant CNS response to the first time osimertinib in patient with EGFR mutated non-small cell lung cancer. What we could see was that it had a very good response, and it has a good blood-brain barrier penetration. And so it becomes one of the drug of choice if you have any kind of brain mets there. So both systemic and clinical benefit were observed if you used osimertinib. No hypothetical scenario, would you, if you have PD-L1 positivity, Dr. Chandrakant, you can take it. Would you like to give?
So there is, even if the PD-L1 is 100% in a patient with a target, driver mutation being there, it has no relevance. Absolutely no relevance. At any point, either localized disease, advanced disease, later on rebiopsy, anywhere.
NCCN have also modified when they give this page in their latest version, they write that there is no driver mutation. So that's their starting headline. Yeah. Rightly said.
Okay. And one important thing, okay, we can go. You had made a very big statement, even if 100%, then also we are not supposed to use it. So I think you have killed most of my further questions. I
asked the similar question to the author of the Archer. He said the same sentence. So I actually repeated that.
Amazing. So I think you have driven home the point that no further discussion on this. So if if you have an EGFR positivity, you have to treat EGFR. Forget about IOs. Okay, fair enough.
So just one point. I know it's a very small subset, but some NSCLC will have a progression from NSCLC and a conversion to SCLC. And the same setting, if the PDL1 is 100%, and that say EGFR positive metastatic NSCLC is now progressed in form of SCLC. What you routinely do? I don't know. I have seen 1 or 2 cases, and I was always stuck. What to do with this patient?
Dr. Chandrakant, would you take it?
I know we had a real world case, what Ashutosh is discussing with us. The concern is pneumonitis, a TKI followed by IO or a IO followed by a TKI. The risk of pneumonitis is too much. So we need to be cautious. There is no data, there is no straight way to address this answer. So even in a small cell, there is some amount of driver mutation being there, it's a heterogeneous group. So I would really not go for a small cell. I would not offer Imfinzi or Tecentriq if it has risen out of a EGFR mutant lung cancer.
Okay, let's take another scenario. Let's have a normal non-small cell lung cancer, and he was EGFR positive. We did all the tests, and we gave him osimertinib or whichever the drugs that we gave, and he progressed with another lung lesion, re-biopsy, both as in tissue biopsy and as well as maybe ctDNA liquid biopsy. All of them are now EGFR negative. Okay, now what? Would you like to give an IO to this patient?
No. So once EGFR mutated is mutated, IO you can give as a ABCP. We have the ABCP trial which has shown some benefit in this subgroup. But I believe the moment there is EGFR, the driver is EGFR. You need to have the EGFR component in your systemic therapy, and chemo, VEGF, this is what you would combine. And you would reserve IO for, when you've exhausted everything, when you don't have. So ABCP is an example, and the hazard ratio is not that great, ERLO, RAM, ERLO, PAVE hazard ratios are excellent. So I believe that if there is a driver mutation, basically if you have a driver mutation, the TMB is low, right? So there are not many mutations being there. It is a single driver that's actually driving the whole cancer. So the moment there is a single driver, you don't have a higher TMB. There are not many new antigens actually. So therefore, in EGFR mutant or any driver mutation being there, even if you look into KRAS mutation being there, even that subset, even a BRAF mutation being there, IO doesn't work in that subset. Therefore, driver mutation means less tumor mutation burden, less new antigens, not IO mutated disease. It's probably a VEGF you need to add or a chemo you need to add. IO comes down the line. So this is the understanding up till date. Maybe in future it may change, but this is how the understanding is up to date.
But I think what Dr. Ashutosh brought in the case of small cell, I need to, put in some more, because I would rather, okay, let's keep this discussion to some other time. Okay, so, okay, this part is clear. So how important is safety profile? I think all of us have been giving osimertinib for quite some time, and we do realize that it is much more better tolerated than, I would say, than dacometinib or even afatinib. I think osimertinib's tolerability is much more better. So we all have been using it. So I think we do understand. So let's rush through these things. And among us, EGFR TKI, second generation EGFR are unfavorable tolerability profile. I think that has been my take also, that probably I had issues with giving dacometinib and never had an issue with osimertinib. Yeah, so I think dose reductions, yeah, so a good tolerable drug, we all know. So does quality of life matters? Definitely, I think we all will agree. That's the basic thing, that we all need to have a good quality of life. So osimertinib did show that it had a better and improved quality of life than compared to others. And similarly, all the trials have been compared, the Archer and Flora, and global quality of life significantly worsened with dacomatinib group versus geftinib group. And one of the treatment goal in metastatic is definitely to have good quality of life. And second generation TKIs generally worsen it. So when would you consider a sequencing approach? Dr. Ashutosh, would you like to take this?
Oh, sequencing as in giving first generation.
Yes. Yeah, correct.
I think if we start with osimertinib, there is no real data for any other TKI to be given after that. Very special subsets like C797S, there is some sensitivity to gefitinib. But if we start with some other TKI and we found that there is a T790M, and osimertinib is an option. But so the talk here is about osimertinib. So I think after osimertinib, there is not much scope of any other TKI. The only thing remains is chemotherapy.
I think we all will agree to it. So the whole idea is that once you are given osimertinib, you are given the best shot. So there could be further discussions, but let's keep it to that. The reason why we want to give osimertinib upfront is that few of the data shows that if you do not give it upfront, then probably 1 out of 3 patients would not be in a condition to actually get it in the second or third line. And another important thing, which I think every time comes across, is the GeoTag trial, which shows that if you give afatinib followed by osimertinib, is it very good or not so good? So there is always a debate on that, whether GeoTag was a good study which can actually, fight Flora trial results. But definitely it was a retrospective analysis which was done, and it excluded a lot of T790 mutated negative, and also the people who had died on the first line of afatinib, and there could also be people who had excluded who did not receive second line of therapy. So more or less what has happened is GeoTag, though it had a very promising outcome, but since it was a retrospective analysis, it could not hold ground in front of Flora trial. So these are exactly my understanding of the study. So with this, I think we could conclude that definitely osimertinib resulted in significant improvement in PFS of almost 8 months extra compared to geftinib. And it had a statistically significant and clinically meaningful improvement in the CNS affected group of patients. And it can, given as a monotherapy, it has a good outcome. Overall survival also improved drastically, and it has a good safety and toxicity profile. So with this, I would like to conclude that definitely osimertinib is one of the, I would say it has become a standard of care as a first line in EGFR mutated lung cancer. So with this, I would like to conclude. If there are any comments.
Well moderated, sir.
Thank you. Thank you. If there are no further questions, I think the organizers could take it over. Yeah.
So thank you so very much, Dr. Abhishek sir, for such a brilliant, moderation of a panel, and I think this has been endorsed by Dr. Chandrakant as well. The best part is for this, I mean, we can see, the vote for having the scientific discussion at this point of time. It's almost all past 10 now. So we take this opportunity to thank each and everyone who has participated in this webinar today. Thank you, Dr. Abhishek. Thank you to the speakers. Thank you to the esteemed panelists to be a part of it. And of course, thank you to the sponsors, AstraZeneca, for helping us out and getting us together, and our academic partners in TAS Oncology, Alkem, and Medgenov. With this, with your permission, Dr. Abhishek, thank you so very much. Thanks everyone for your participation. Stay safe, stay blessed. Good night from the entire organizing team, my colleagues from Ankit and Garima. It's time to say goodbye and stay safe.
Thank you, sir. Thank you, Abhishek, sir.
Thank you.
Thank you, everyone.
Thank you, Dr. Abhishek.
Thank you, everyone.
Yeah, thank you. Thank you, Dr. Ashutosh.
Thank you, Dr. Abhishek.
Dr. Pradeep, thank you, sir. Thank you.